Yes, ma'am, we are live.
Good evening, everyone. Myself, Dr. Saurabh Kiste. So, on behalf of Nephrocon, I warmly welcome you all to today's academic session, which is HRS-AKI and beyond, navigating the evolving landscape of hepatorenal syndrome. So, as we all know, HRS remains one of the most challenging sections between hepatology, nephrology, and critical care team. And over the last few decades, we have seen that our understanding is evolving significantly. So from viewing HRS as purely functional renal disorder to recognizing a far more complex situation where it involves systemic inflammation, circulatory dysfunction, tubular injury, and even multi-organ failure. So to discuss this further, we are privileged to have an outstanding panel with us today. As a speaker, we have Dr. Raki Maiwal, who is a renowned hepatologist and critical care specialist with extensive expertise in ACLF, total hypertension, and liver intensive care. She currently serves as head of unit at liver intensive care unit at ILVS New Delhi and has contributed significantly to research and international guidelines in advanced liver disease and hepatorenal syndrome. And as a panelist, we have Dr. Mahesh Kota, who is a leading nephrologist from Yashoda Hospitals, Hyderabad. He has special interest in critical care nephrology, AKI, and extracorporeal therapies. And also we have Dr. Pawan Hansanare, who is a panelist here, and he's a renowned hepatologist and liver transplant physician associated with Jupiter Hospital, Pune. And as his clinical expertise include advanced liver diseases, transplant hepatology, and management of ACLF with multi-organ involvement. Over to you, ma'am.
Okay. Thank you so much. And it's a pleasure for me to be here and to deliver a talk and talk about the evolving concepts. What I'll try to do in the next 30 minutes is to talk about how this field is rapidly evolving with respect to the understanding and how are we changing our assessment and both the management of HRS-AKI, and we'll be discussing about the landscape of the syndrome. So the novel concepts that have occurred in the very recent past in the pathophysiology. Am I audible?
Yes, ma'am. Yes, ma'am.
Okay. So in the pathophysiology of acute kidney injury in patients with cirrhosis, so we know about the portal hypertension, which causes the splanchnic arterial vasodilatation, effective arterial hypovolemia. There is activation of the vasoconstrictor factors, the renin, angiotensin, aldosterone system, sympathetic nervous system. And also there is renal vasoconstriction causing a decrease in the GFR and impairment of the renal autoregulation. But what has evolved in the recent past is the understanding and the role of the cirrhotic cardiomyopathy or the heart in the assessment and the management of kidneys in patients with cirrhosis. The bile cast nephropathy, which we have seen very commonly in the context of acute and chronic liver failure, which was previously unrecognized. And I'll be trying to show you how the diagnosis and the management of this entity makes the overall differences in the clinical outcomes of the patients. And of course, the systemic inflammation that our panelists were talking about and the peripheral vasodilatation, which are of extreme importance because these are where, which causes the circulatory dysfunction, and the systemic inflammation hypothesis, where again, the use of albumin and other therapies to counteract the inflammation becomes very important, specifically in the context of infection. So we also know that very recently now all the people from the International Club of Ascites had gathered together to understand, and we together as a team, along with the nephrologist and the intensive care specialist, recognize the significance of the urine output, which was initially not considered. So even though everybody doesn't need monitoring of urine output, once you're dealing with sick patients of liver disease, specifically in the context of acute and chronic liver failure and in the intensive care unit, it becomes important that that we recognize AKI not just based on the relative increases in the serum creatinine or absolute increase, which is defined as an increase of 0.3 mg per dl within 48 hours or a 50% rise from the baseline value at day 7. It is also important that urine output should be considered as a very important surrogate. So we've shown that in the context of critically ill patients with liver disease, where there is sarcopenia, there is volume overload and different other factors, even the severity of jaundice, the urine output measurement actually precedes the changes in assessment of AKI when you go by the creatinine criteria. So it's also necessary for us to understand that a patient of ACLF, and this is where with the International Club of we had proposed in the APASL and as a group of experts, that in patients, when you're dealing with ACLF, you see very high serum creatinine. But in this set of stage 3 AKI patients, we see again 2 sets of patients who require renal replacement therapy. One who are those who have preserved renal output or urine output, and the ones who are oliguric and have high serum creatinine or stage 3 AKI. So even though there are no guidelines, we propose that the outcomes of these patients, specifically when we are also considering the liver transplant and the selection of patients on RRT, this becomes a very important factor that should be considered in the decision making and assessment of these patients. So I'll again talk about a little bit more about the understanding of the baseline serum creatinine. So the baseline serum creatinine also has been redefined. Previously, we said it is the stable and the most recent value of serum creatinine, which is available for the patient in the last 3 months. But now we recognize that it can be, if it is not available in the last 3 months, we can go over to the last 12 months. And when there are multiple values of serum creatinine which are available, we can use the median value or as judged most relevant based on your clinical assessment. And wherever there is no available baseline serum creatinine, it is suggested that the admission serum creatinine or a reverse calculation using the estimated GFR calculator can be recommended. But again, this is not very reliable, and wherever possible, we should try and dig out the baseline serum creatinine of the patient in the stable state. Now, the relevance of baseline serum creatinine is not only for the diagnosis and staging of acute kidney injury, it also tells us about the duration. So whenever we are seeing patients with cirrhosis, it is not necessary that every patient has acute kidney injury. We may be dealing with subacute renal dysfunction or acute kidney disease. Underlying chronic kidney disease also should not be missed. So this becomes very important. And while you're assessing the response to the different therapeutic interventions, this becomes very important because this is where you would like to have your patient to reach to say that the patient has achieved a partial or a complete renal recovery. So the assessment of baseline kidney health, which was previously the concept of HRS was thought that it is always functional, is now evolved. And we know that AKI HRS can also occur on the background of a patient who has subacute or acute kidney disease or a chronic kidney disease, and also in patients with normal kidney function. And again, when the patients you're dealing with HRS and they have progressed to a state of severe AKI or prolonged AKI, they can also, with a normal kidney disease, can actually progress to acute kidney disease or chronic kidney disease. And therefore, the evolution of the kidney health will change based on the renal recovery. So patients with maladaptive repair may have prolonged and persistence of AKI, and they have the ongoing tubulointerstitial inflammation, which can result in the slow development of renal fibrosis and the development of chronic kidney disease in these patients. So this is a cartoon which I wanted to show here, that when you're dealing with kidney dysfunction, we do not say AKI, but if you're dealing with kidney dysfunction in patients with decompensated cirrhosis, it is rather more complex than simple. And we have to understand that we should be seeing that there can be acute components which can also be mixed. So a patient may have a diuretic-induced AKI and may also have the intrinsic forms of AKI, such as an IgA nephropathy, or they can be an obstructive component on a baseline of chronic kidney disease. So there can be a lot of overlap between the different syndromes. So it becomes very important for us to understand what is the baseline kidney status, what is the acute kidney injury, whether the patient has any form of structural kidney injury, and that becomes extremely important in managing and assessing these patients. So to keep it very simple, when we're dealing with pure AKI, we can classify these patients as functional or structural. The functional are mostly pre-renal or hypervolemia related due to several factors, which can be easily got from the clinical history. And obviously, a pre-renal AKI, which is not responsive and is functional, will be actually classified as hepatorenal syndrome once we've achieved the volume expansion and the patient has shown non-response. The structural, on the other hand, can be either an acute tubular injury or necrosis, a bile cast nephropathy, and any of these patients may have background sepsis-related problems, which can also cause some form of tubular injury in these patients. So the group together, we also try to define that it is now important that whenever we're dealing with patients with cirrhosis, it is not purely acute kidney injury. It can be acute or chronic kidney disease. And now more and more often with the advent of the metabolic dysfunction associated steatotic liver disease and the other chronic diseases that we're seeing in these patients and the recognition of the HRS-CKD phenotype, we understand that almost 70% of patients with cirrhosis may have some form of chronic kidney disease. So the patients may have AKI, but again, it becomes very difficult exactly to define and manage these patients. So again, we need more data in this context to understand and define the management. So as a group together, we also redefine the HRS, and this is the most recent consensus paper that was published, where we said that HRS-AKI can be more simplified way of saying that it's a phenotype of AKI that is very specific to patients with advanced cirrhosis, and these patients should have significant ascites, and this may occur in the presence of some form of tubular injury and also pre-existing chronic kidney disease. So it's not necessary now to say that it is almost functional. The patients may have some form of structural kidney damage in the background, and you may still have a patient with HRS-AKI. So the patient, again, we've defined the criteria that there is no need for us to wait for 48 hours challenge of albumin that was initially proposed. You have to consider urine output based on the severity status of the patient, and based on the volume status, you can consider even initiation of vasoconstrictors early on within the first 24 hours. Even at onset, if your patient is euvolemic and you receive the patient who's already received albumin from outside. So it also depends on the stage in which you're seeing your patient. So it's not necessary that every time you start with these 48 hours volume challenge to make the diagnosis of HRS-AKI. And again, we have to be, when we're dealing with patients with background tubular injury, we have to be very sure that we're not dealing, and there should not be a strong evidence for an alternative explanation of the primary cause of AKI, such as the septic shock, which is requiring dual vasopressors. There is a clear cause of nephrotoxic ATN obstruction or acute glomerular diseases. So when we say AKI, I talked about phenotypes can be functional or structural. And similarly, for chronic kidney disease, again, we say that we can classify them very simply as functional. That is the HRS-AKI and AKI phenotype, the previously called as type 2 HRS patients. And why this functional and structural classification becomes important, because structural is where the disease is in the kidneys itself. So SLK, a simultaneous liver kidney transplant, will be obviously required if you're making a diagnosis of structural CKD. However, if you're dealing with the functional phenotype of AKI, many of these patients who actually meet the diagnostic criteria of CKD, and they may resolve just with liver transplant alone. So this distinction becomes very important in the context of patients where we are considering TIPS, where we are considering liver transplant or SLK. This distinction may become very clinically meaningful. So this is what we have suggested. So whenever we are assessing our patients with liver disease in the baseline stable state and they are not admitted and had no acute complications, you have to put up the serum creatinine of baseline. It's better to calculate using an estimated GFR equation. What we propose is a creatinine cystatin base CKD API equation for patients with cirrhosis, a urine analysis to rule out obvious proteinuria or a structural form of kidney injury, and and a kidney ultrasound or imaging of the kidneys to understand that we're dealing with a normal kidneys or a disease which is there and of structural phenotype. And subsequently, if you're dealing with an AKI, there is a way to calculate the staging of the patient based, and again, you phenotype the cause of AKI. And if you're dealing with CKD, we go by the criteria of the GFR to grade the stage of CKD and also the albuminuria categories, which can tell us about the proteinuria and the CKD stage and grade. So what is the relevance of this? And this is a very recent paper which actually looked at how this new definition of considering background CKD would influence the response to the therapeutic management of HRS-AKI, which we're giving, like terlipressin. So this was what we had been doing over the years, even though these diagnostic criteria were laid down. But practically and in a pragmatic approach, all of us were treating these patients with terlipressin. So this is the study from which is a retrospective series, a large cohort of patients, and from Europe, where they included 395 patients with cirrhosis who were retrospectively managed, and they just tried to phenotype what were the outcomes of HRS-AKI based on the revised criteria or CKD presence or absence. And what they found was that the response to terlipressin was not a problem, and it was equivalent whether you had CKD in the background or not. But what was different was the development of more pulmonary complications or pulmonary edema with the use of albumin and terlipressin when you're giving and managing HRS-AKI on a background of chronic kidney disease. So again, this brings us to a new concept, whether HRS can be an underfeeling phenotype where you respond to your albumin, or a high venous pressure where you have some form of cardiorenal phenotype, and you have to be very careful with the use of your albumin. Because in the congested patient, if you give albumin and terlipressin together, these are the patients who can land up into severe pulmonary complications and pulmonary edema with the use of this combination. So the assessment of volume has become the central part in the management of AKI, particularly when dealing with complex AKIs on a background of CKD in patients in the ICU, severe AKI stage 3 in the context of septic shock or circulatory dysfunction becomes very important to have a dynamic assessment of the volume status. And this is a data, even though we believe that the IVC may not be reliable, but yes, it can be a very good surrogate. And we have our own data, and this is a data in the context of decompensated patients with cirrhosis who were undergoing large volume paracentesis. These were not patients with AKI, but they showed that IVC guidance and the use of POCUS was helpful to understand the patients and the risk of pulmonary complications with the use of intravenous albumin. So when you're dealing with these patients, therefore, when we're talking about the underfilled and the congested phenotype, if you look at the IVC below 1.5 centimeter in the context of a cirrhotic patient who has ascites and AKI is the underfilled phenotype, while the IVC, which is more full, that is above 20, which is non-collapsible. If you're doing a VEXUS along with it, that is, you can include a renal venous outflow, a portal vein, or you can do also a velocity time integral if you're doing these managing these patients in the ICU. These can give you a very good surrogate of how to manage these patients and whether you should be giving an aggressive volume or pressors, or you have to give a decongestive therapy and do ascitic taps, obviously in these patients in the congested phenotype, and see how much albumin you have to give, because there you should not follow that protocol of 1 gram per kg albumin that was previously recommended. So we've proposed specifically in the context of acute on chronic liver failure. These are very sick patients. It is very important. And IVC, we still feel it's a very good, reliable measure. If you can do central venous pressure measurement, central venous pressure is not outdated. If it is low, yes, we can obviously go ahead. But yes, even with patients with high CVP may still have a response to volume challenge. So that way, CVP also becomes an important surrogate when we're dealing with sick patients. So it is not completely out, and it also gives useful information. Now, the other debate which I would like to talk about is about whether you should be just purely giving albumin to patients with HRS-AKI, or we can use crystalloids and a combination of albumin. So again, the group is divided and there is a lot of debate, but now we all believe that it is not necessary, and this is our own data also where we showed that if you're giving and if the patient needs more resuscitation and more volumes, it is difficult to give 20% or 25% albumin in such patients in high dosages. So you don't want to give crystalloids alone, but a combination of crystalloids and a slow infusion of albumin in such patients where the volume of fluid required is more, or 5% albumin can be used when you have a patient who has severe AKI in shock, where you cannot give large dosages of 20 or 25% albumin. So what we need to target is the mean arterial pressure. So whenever we are giving the volume management, we're doing these vasoconstrictor therapy, our main target in these patients should be to achieve an appropriate MAP. Because if we achieve an appropriate MAP, this is what will improve the renal perfusion, and this is associated with better outcomes with respect to both critically ill patients and non-critically ill populations. So a target MAP above 75 in the context of septic shock, and when the patient is stable, a target MAP above 80 or 85 may be good with the use of terlipressin. But when we are using terlipressin, the problems and the challenges is you get more adverse events, and we should understand where we are likely to get more adverse events. It is the patients with cardiac dysfunction, patients who are more sick with advanced liver failure. When you're dealing with a patient with a sicker phenotype, that is patients where they already gone to a phenotype where the HRS has probably progressed to a stage of acute tubular necrosis, or the patient has developed severe renal ischemia, respiratory patients with respiratory failure or on ventilator. So these are the patients with pneumonia. They are more likely to have more serious adverse events with terlipressin. So cardiac function assessment along with the POCUS can be very helpful, because a hypodynamic heart or a cirrhotic cardiomyopathy is associated with worse outcomes. Terlipressin is also used in the Terlipressin can also be used, and this is a global study data across the globe where we were also participated, just to show you that people are using terlipressin not just with the diagnosis of HRS-AKI, even pre-renal patients have received terlipressin, and patients with acute tubular necrosis. But if you're giving terlipressin in patients with ATN, these are the patients who will not respond to terlipressin. Of terlipressin also from our center in the context of ACLF, we showed that in patients with ACLF, you don't need to wait for 48 hours because they have rapid progression of AKI. So we can initiate terlipressin early on after we have done an appropriate volume expansion. The use of biomarkers is also one area which is important, and the big distinction when we're dealing with sick patients, supposing a patient comes to us with a creatinine of 5, and we do not know whether we're dealing with a hypovolemic or functional AKI, which has the patient has severe AKI, which is HRS-AKI, or we are dealing with ATN. So here is where we need the support of biomarkers, and urine NGAL is the most validated biomarkers. And again, it has been shown from our patients in India. We have published from Asian patients. We've shown the relevance of urine NGAL, and also from Europe and America, US, everywhere. So now, at least in the hepatologist, and I would like to discuss with the people here in nephrology, that urine NGAL, we believe, is a standard and most validated marker to make that differentiation of HRS from ATN in the context of sick patients. So this is our data. We showed that NGAL above 900 in the context of patients with ACLF, we can make sure that this patient is unlikely to respond to terlipressin. I will also touch upon the urine microscopy's role as a biomarker should never be forgotten. So we should carefully look at the urine microscopy. If we do not have the biomarkers like urine NGAL available in our setup, it's very simple to look at the urine microscopy, because we showed that if the patient has HRS-AKI, most of the times the urine microscopy is bland unless and until we're dealing with mixed phenotypes of AKI. If you have granular cast and you know that you're dealing with ATN, ATN, if there is RBC cast, or if you have bile crystals in the urine microscopy, you know that you're dealing with a possibility of in a jaundiced patient with a chylemic AKI. And this diagnosis becomes very relevant because I'll show you some very interesting data of how this distinction from ATN in the context of ACLF. So every jaundiced patient is not having chylemic nephropathy, but yes, for chylemic nephropathy, the patient has to have severe jaundice. So most of the times these patients are deeply jaundiced. The bilirubin average is above 25. And most of these patients, the chylemic nephropathy occurs in patients with acute on chronic liver failure. The tubule injury in these patients is distinctly different from acute tubular necrosis. And in patients with ACLF in histological diagnosis and postmortem studies, we showed that majority had chylemic nephropathy as against acute tubular necrosis. So chylemic nephropathy patients, we showed on IHC staining of these postmortem kidney biopsies as against ATN, that these patients had preserved mitochondrial function and increase in the SIRT1 expression on the renal tubules as against the hypoxia-inducible factor in acute tubular necrosis. So what happens to patients with ACLF? So this was a very recent study which we just published to show that ATN is distinctly different from HRS and chylemic nephropathy. So patients with chylemic nephropathy and HRS are very similar with respect to the renal biomarkers. Patients with ATN have more severe tubular injury, but the patients with chylemic nephropathy are intermediate between ATN and HRS-AKI. So they behave more like HRS-AKI. They have partial response to terlipressin. Their bile acid levels, if you're measuring, these have high bile acids. They have bilirubin crystals. They have severe systemic inflammation. And I do not have time to go into details of this study, but just to highlight that it becomes important because this chylemic nephropathy is distinctly different from acute tubular necrosis, and it is driven by severe systemic inflammation, bile acids, and this is associated with preserved mitochondrial function in the renal tubules. And therefore, these patients respond very nicely to your extracorporeal therapies, which target systemic inflammation and cytokines. And we've shown again that in urine microscopy, if you're looking at some tubule epithelial cells, these are markers that you're dealing with a form of HRS where there is some form of tubular injury. So this could be another marker in case we're not doing urine NGAL to show that these patients are likely to have some form of tubular injury. And why this becomes important is when you're looking at chylemic nephropathy, we see that the terlipressin response is less as compared to patients who had HRS-AKI. So your terlipressin response is lesser in patients with chylemic nephropathy, is not seen in patients with ATN. And therefore, this diagnosis, which is important, is also associated with clinical outcomes. So the management of HRS-AKI, our first-line drug is terlipressin. We can use norepinephrine or sometimes even a combination of norepinephrine and terlipressin where we cannot give high dosages because high dosages are associated with adverse events. So combining low dose of terlipressin infusion can also be very helpful. The non-response is basically, as already mentioned, the same factors which determine adverse events also determine non-response to these patients. And for acute on chronic liver failure, the field, how it is moving is we have to identify because almost 70% of the patients are having structural AKI. Most of the times, the response to terlipressin is seen in only 20 to 30%, and we're dealing with mixed phenotypes. We have chylemic nephropathy, acute tubular necrosis, where there becomes a role of these extracorporeal liver support modalities to be combined along with maybe a CRRT to handle the kidneys in these patients. And why this response is important, even if you're going for a liver transplant, if you're achieving a response in the management before transplant, this also has implications post-transplant because patients who were non-responders, they had more frequent requirement of renal replacement therapy post-transplant as against patients who were responders. And this is what we recommend for patients with acute kidney injury from the APASL, that we should consider preemptive initiation of CRRT, even though I know there are no hard randomized control trials, but as a group, we all believe that CRRT is better as compared to SLED in patients with ACLF. And wherever there is a non-response and the patient has progression, we should consider initiating CRRT in these patients. So this is our recent data. This was not an ACLF. This were critically ill patients, a very difficult study. Now we have abandoned almost in our ICU doing SLED and septic shock. But these were the earlier days where we did SLED. And we showed again that waiting for the absolute criteria, and specifically when you're doing these intermittent hemodialysis in these patients, these were associated with very rapid worsening. And most of these patients were dying in the first 7 days due to severe hypertension with dialysis. So in context of liver disease, as against contrary to other, the data is not there, but this is again, we have shown that even though the outcomes at 28 day were not different, but hypotension with dialysis was very common in the context of sepsis and septic shock in critically ill patients with liver disease. So it is better wherever possible, where the cost is not a problem, you have the expertise, you have the resources. It is better because a lot of other factors also drive these decisions. But in the clinical context, a CRRT is better with respect to clinical outcomes in patients with liver disease. A therapeutic plasma exchange can also be a very good modality, but it can be useful in the context of management of chylemic nephropathy. And we have some data to show that it clears the bile acids and can be associated with better outcomes. Adsorption strategies as compared to plasma exchange. This is again the data from our center where we showed that in the context of sicker patients of ACLF, an adsorption strategy is better as against a plasma exchange. So I would like to conclude by saying there are newer timelines for AKI HRS. We understand and the field is evolving. The uniformity in diagnostic criteria is still lacking, but we're understanding how the syndrome is very difficult to diagnose and the way variations in the patients that we see. The pathogenesis revolves around structural changes which is driven by systemic inflammation, sepsis, maybe chylemic nephropathy, biomarkers. Urine NGAL is something, urine microscopy should be carefully seen in these patients. Terlipressin use has to be optimized. We have to see how we give a continuous and low dose terlipressin in the critically ill patients, and looking and monitoring for adverse events is very important. Volume status and MAP targeting is very important, and assessment of heart should never be forgotten in these patients. And I would like to thank you for your kind attention.
Thank you very much, ma'am. It was an excellent talk, and you covered a lot of our doubts were actually solved in this presentation.
Thank you.
I'll proceed to the next section where we'll be discussing some questions. We have prepared some questions for panelists as well as you.
Okay.
And I'd like to proceed to that.
Should I stop sharing? Yeah.
Yeah, that's okay. So my first question will be to Dr. Mahesh Kota. So
yes,
in a patient with decompensated CLD who is presenting with elevated serum creatinine, so how do you proceed? When urinary biomarkers suggest structural damage, but the clinical phenotype still remains suggestive of functional impairment. So in your practice, how do you proceed, sir?
So in my practice, I would go by one criteria. We know now in this 2026 era, we are very clear about the pathophysiology of hepatorenal syndrome. And it is not a one entity which is causing the renal dysfunction. It is a combination of pre-renal element and intrinsic renal element. This pre-renal element is not a pre-renal AKI which is caused by volume loss in a patient with a diarrhea or any other hypovolemia. This is a functional pre-renal element, and it is definitely considered to be a separate phenotype of a pre-renal element. So even though if the patient is having adequate intravascular volume, but that is not going up to the level of kidneys to cause a proper perfusion. We have to understand pathophysiology of HRS as a phenotype where there is significant splanchnic vasodilatation and significant intrarenal vasoconstriction because of the different receptors which is there in the splanchnic circulation and the receptors which are present in the renal vasculature. So at a particular point of time, without having a biomarker like NGAL, we cannot easily differentiate this pre-renal element versus intrinsic renal element. Though we don't use regularly biomarkers in our unit, but we can come to a conclusion that biomarkers are very important things in diagnosing a patient with hepatorenal syndrome. And when it comes to establishing the renal function, as because of the significant muscle loss in these patients because of the chronic illness, the creatinine might not be a particular marker for renal function. And at the same time, urea is also not a significant biomarker because the improperly functioning liver may not be able to produce the amount of urea, and at the same time, yes, you need to monitor definitely urine output. But because of the poor perfusion to the kidneys, the urine output may not also be a great marker. Yes, you have to, if the patient is having a proper amount of urine output 48 hours before, and now if the patient doesn't have a good amount of urine output, yes, you can consider. But as madam suggested, this hepatorenal syndrome can occur in a patient who has already some amount of chronic kidney disease or previous some renal dysfunction. So in those group of people, urine output may not be adequate enough to diagnose the patient is having hepatorenal syndrome. So yes, for your question, straightforward answer is biomarkers are definitely a important thing to diagnose hepatorenal syndrome. And along with NGAL, I would just like to add urinary cell cycle arrest biomarkers like TIM2 and IGF-CT7. They will become a promising biomarkers in future in any patient with a pre-renal kidney injury.
Okay, sir. But currently, NGAL in your unit, you are not using NGAL as a regular
We
parameter.
have when I think we have started measuring TIM2 and IGF-V BP7 from 2018. Even before that, Girish sir has an good experience with NGAL when he was in Care Hospital, Hyderabad. So in the before 2017 or 2015, yes, urinary biomarkers which like NGAL, cystatin C, they were used to predict the pre-renal element. Yes, if it is available in your unit, definitely you can consider NGAL. But if you have both NGAL and other biomarkers like cell cycle arrest biomarkers, there is enough amount of data to show that these biomarkers can predict the pre-renal acute kidney injury better than NGAL. And the area under curve for these particular biomarkers are definitely more than the NGAL.
Sure. Uh, now coming to albumin usage. So what is standard duration of an albumin expansion trial before you deem it as a failure? In your unit, we are talking.
Yeah.
Your unit.
So in our unit, as Madam suggested, there is no particular time period till what time we have to give albumin, and at that same point of time, we should consider okay, the plasma volume has expanded now. Okay, stop albumin, go ahead with any other treatment approach. But at the initial point of time, see if the patient comes to hospital with pure hepatorenal syndrome, which is very unlikely because most of the patients in Indian scenario, they will be coming for hospital with history of multiple large volume paracentesis sessions, and they will be having these episodes of a renal injury previously also. But if as per the guidelines or as per the textbook, if a patient comes to hospital with the first episode of hepatorenal syndrome, and if the patient doesn't have any chronic kidney injury, or if the patient doesn't have any CKD element or whatever it is, if the patient doesn't have any sepsis, yes, I would like to expand the plasma volume by giving albumin infusion for at least 48 to 72 hours. And I would also consider the role of terlipressin if the patient doesn't have any kidney injury. I mean, like, yes, I would accept the fact that terlipressin being a selective vasopressor agent, it acts in a better way in a splanchnic circulation rather than renal circulation. I would consider first 3 days of terlipressin as an infusion, not an intermittent doses, as an infusion low dose along with albumin for at least 3 days. Then at least if I am very clear that I have expanded the patient volume enough in such a way that it is not, this volume expansion is not causing further injury to the patient, I am okay to give albumin.
Okay. So actually, third question you already answered in a way, but still, so albumin should we really be utilized primarily as a diagnostic challenge for HRS differing terlipressin initiation, or as a temporary measure before RRT escalation?
Before escalating to RRT, I would like to take this notice that albumin here in hepatorenal syndrome, it is not only acting as an oncotic agent or plasma expander. It has an anti-inflammatory properties, and it is proven very clearly in multiple studies that this acts as an agent that decreases the inflammation and that decreases the chance of spontaneous bacterial peritonitis. If we know that these group of patients they are at the high risk of gut translocation from the of these bacteria and endotoxin, and this gut translocation will be significantly high for a patient who is having a very low oncotic pressure. So this albumin, rather than expanding patient's volume, it also acts as an anti-inflammatory agent. So I would like to definitely consider to give albumin infusion for first 72 hours, and then if the patient is not responding, or even if the patient is responding, definitely after 72 hours, if the patient has any other indication for renal replacement therapy, we would go for that.
Actually, same question I'll like to ask Raki madam also. So in the same, in your unit, how do you practice albumin and terlipressin? Combination wise or strict? Ma'am, you're on mute. Ma'am, you're on mute.
So what we do in the ICU, I would talk about first is the critically ill setup. So in the ICU context, we can have two sets of patients. One is the patients who have shock, which is like severe shock, and they have AKI with metabolic acidosis, where we are considering volume expansion and the patient is volume depleted. That set of patients. The second set of patients is where the patient is not having or some circulatory dysfunction, other complications like pneumonia, HE, hydrothoracis, means the patient is not in severe shock, where the volume expansion is not needed. And the third context is obviously a patient whose volume replete and hypervolemic and going into shock. So that's a separate where we don't give volume expansion. So in the patient where there is severe shock and so we will give albumin, obviously. So we prefer 25% or 20% albumin based on the serum albumin level. If it is too low, better to give 25%. So we will add it as a infusion, but the volume is supplemented with crystalloids. So we will give maybe, I would say 75 to 100 grams of 25% albumin to such a patient who's in severe shock. But the more volume is given by crystalloids, and we prefer balanced crystalloids like Plasmalite. In the second context is where the patient is not in shock, is maybe U or hypovolemic phenotype, where he's not crashing on us but has AKI. So there I would not pump in crystalloids, and with whatever the benefits Dr. Mahesh also alluded to. Albumin is the preferable choice, and we should not pump in too much fluids because then they land up with a lot of ascites development and these patients go into volume overload. So we have to be very careful in that set of patients, and albumin is a better volume, and we can go slow because the patient is not crashing on us. So that is how we do. And the third context is where the patient doesn't have a tolerance to albumin. Like I said, some patients' tolerance is not good because of the cardiopulmonary dysfunction. So once you start albumin, they start coughing. So that set of patients, obviously there, if we have to give volume, that set of patients, we may give crystalloids and we may avoid albumin in that set of patients.
Absolutely. Coming to terlipressin part, so does the current evidence in your practice favor continuous infusion, or you prefer intermittent bolus dosing for terlipressin?
So If you ask me, see, continuous infusion has been shown to be better. But I'll tell you, if I am dealing with very sick patients, I've seen that the moment you start them on high dose, maybe 2 mg or more, they start getting adverse events, even with a continuous infusion. So terlipressin needs very close monitoring. And now what I have done is I can share with you how I've changed my practice, even though I know continuous infusion is better. We to use continuous infusion. But when we're dealing with the sicker set of patients, we give terlipressin bolus, maybe 0.5. We mostly manage these patients with norepinephrine. We look at the MAP response with zero point 0.5. If the patient has responded well, then we may consider maybe 1 or 2 more. And if the patient has shown response, we do not need more terlipressin. We maintain it with norepinephrine. However, if the patient has not shown any response to the terlipressin, we know that unnecessarily starting an infusion of terlipressin in such a patient who has not shown response may land up with adverse events. So there we try and put that set of patients on vasopressin rather than giving terlipressin. If you have to maintain a good mean arterial pressure and we need a second vasopressor or good vasoconstriction, so we consider vasopressin in that set of patients. So that is where. In the ward context, in decompensated cirrhosis who are unstable but not critically ill, obviously I can start terlipressin very safely as a continuous infusion. There is no challenge.
So, ma'am, in first set of patients, how much duration you consider whether patient is responding or not responding?
You will see an immediate response when you give 0.5 and you see the monitor after half an hour. So the map improves. If the map has improved, we know the hemodynamics is showing an improvement. We can start the infusion of the patient. And sometimes the patient just responds to one small dose and another 1 mg. And he's, because the day in 24 hours, I think so, I've never gone beyond 1 to 2 mg in a critically ill patient with liver disease. We've stopped using high dosages beyond this. Obviously, that's what I'm saying. In the context of severe systemic inflammation, difficult AKIs, there the challenges with adverse events are also more in my practice. That's why we do not use too much dosages in such patients. We try to give norepinephrine along with that.
Okay. So, ma'am, if the patient is demonstrating improvement in the serum creatinine, but the output is not that great, patient is still remains oliguric. So, do you consider this as a clinical response or
No?
No? And
For me, I'll tell you, I would go by urine output. I know, means again, I would say that in ABG becomes more important, even though it is not written in any guidelines. My metabolic parameters will become more important when I'm dealing with sick patients with AKI rather than, so urine output is one very important, volume status of the patient, mean arterial pressure of the patient, if you're doing SVR assessment or any other surrogate for the microcirculation and macrocirculation parameters, because organ perfusion is very important. So urine output is a very important surrogate for that. So that will be more relevant for me rather than looking at a serum creatinine level. But if my patient is doing okay and the urine output has not improved, but the patient is stable and patient is showing some, we can wait for the urine output also to improve. So I'm just trying to tell you where the blood gases and everything else is also not fitting and the urine output is not improving. There I would be a little more give weightage to urine output. But if my patient is stable, I can wait for the urine output also to improve. Sometimes it takes time and next day onwards, patient starts showing response.
absolutely. So, in such cases, you will continue terlipressin.
I will continue terlipressin.
and
I will continue my albumin infusion. I will adjust my dose of albumin. So albumin dose is very dynamic. I can increase, I can decrease, I can stop. So that volume assessment and those things should continue because albumin should not be fixed dose in the management of HRS-AKI. We should be very dynamic with respect to the volume status of the patient.
That's ICU decision and it's quite dynamic.
Yeah.
So of course, depending on the volume status and the other metabolic parameters, we'll consider RIT. If the patient is not improving and creatinine is also not improving, output is.
And many times, again, I would say where you were talking about urine output, if your creatinine has decreased, in liver patients who are decreasing their creatinine and we are sure we are not dealing with ATN, we can give diuretics also, small dosages of diuretics, so that congestive phenotype and they start pouring urine. So if they are decreasing their creatinine, they are volume replete, they are not in the context, we are not dealing with ATN, we can give diuretics, means some congestion, and you will see that terlipressin and that combination of terlipressin, albumin, and some diuretics in an improving AKI without any other renal dysfunction parameters. They do very well with diuretics as well.
Yes.
Thank you for bringing up diuretics. It
Yeah.
pleases the nephrologist in me.
No,
So-
I'm saying in a very, so I would not give diuretics in the beginning of management for my patient. Yes, but obviously during the course of AKI, we can use diuretics. Congestive phenotypes does improve with diuretics.
So any role of furosemide stress test in HRS-AKI? The
So
furosemide stress
diuretics,
test, which
as against the nephrologist suggest, how I use diuretics, I can just share with you. So we do not give that very high dose of diuretics, which is suggested for the furosemide stress test. A very small dose of I give 10 mg and my patient starts having urine like 200 to 300 ml. So I know my patient has shown a diuretic response. So I will not give very high dosages. I will give maybe small 10 to 20 mg. Go slow on these patients rather than giving high dosages.
Perfect. Thank you.
Ma'am, if a patient has developed terlipressin related complications, so what will be the threshold for dose reduction, or we just completely stop terlipressin and shift to another alternative vasopressors? How do you do?
So whenever the patient develops an adverse event, some adverse events are very serious. The second thing is where they develop loose stools. We see patient starts developing loose motions, alteration of bowels, and they start complaining of those things. So normally I do not give terlipressin. I immediately stop, because that's a important, means it's a like the patient is likely to get a more severe adverse event if the patient has shown adverse event in the initial phase of because adverse events can be very detrimental in these patients with terlipressin. So I would be rather on the safer side rather than giving them, I would stop terlipressin.
So we won't be, you won't be shifting to another vasopressor?
Yeah, we use norepinephrine. That's what I'm saying. So norepinephrine.
Sorry.
Supposing the norepinephrine is not helping, that is what I'm saying. We have done, I did not show because that is another phenotype. But even in early, now your data means the critical care data, because I'm saying not specifically for liver, we've shown in liver as well, that early initiation of vasopressin. So a small dose of vasopressin addition can be very helpful to counteract the severe systemic vasodilatation. So wherever we cannot use terlipressin, our norepinephrine dose is around 0.3, 0.5 mics. We give a very small dose of vasopressin. It's actually very good because it improves the hemodynamics, it improves the SVRs, and it is a good strategy. And we've shown that it is a safer strategy in less severe shock as against giving terlipressin.
Okay. And for the responders, those who are responding, what is your longitudinal follow-up protocol, and does the role of midodrine monotherapy is really validated in outpatient settings?
So I would say that midodrine is a very good drug in the context of outpatients, because we cannot give terlipressin to these patients, even though there is data from US. Now they're giving outpatient terlipressin infusion, even some studies from Europe. But we know that it can be, we cannot advise our patients. So midodrine, if a patient has recovered from HRS-AKI, we will see that these patients will require more, they are benefited by giving a combination of long-term albumin as well as midodrine to target an appropriate MAP, even in that setting when they are discharged, so as to maintain their renal perfusion and also prevent the development of AKI in future. And also we can subsequently see the, again, reintroduction of diuretics after we have built up a good MAP. Then we can obviously reintroduce diuretics after. So that midodrine usage is also very important in that setting.
Thank you, ma'am. It was lovely discussion.
Thank you.
I'll proceed with the next session. Few questions to Pawan sir. Pawan sir, are you there?
Yeah. Hi, good evening.
Hello, sir.
Rakya
Good
ma'am,
evening.
good evening.
Hi,
It's
hi,
indeed
good evening.
pleasure to listen to you
Yeah,
as
yeah.
always.
No, thank you.
Yes, ma'am. Hi, Girish sir.
Hi,
Please
sir.
go ahead.
So, how does POCUS influence management of ACLF or HRS-AKI, especially regarding volume status assessment prior to initiating vasopressors? In your practice, how do you manage POCUS?
So I think Rakya ma'am has already clearly told that see
Yeah.
any patient of AKI, especially the CLD who is coming to you, first thing what we need to assess is a volume status, and then the things roll out from there. So hemodynamic stable, hemodynamically unstable, these are the two criteria as already discussed. If the patient is hemodynamically stable in the wards, then we assess the volume status. Volume status can be assessed. Obviously, nowadays focuses in a lot of discussion everywhere. In our institute, we have our dedicated liver ICU where the focus is done for even patients who are coming, even going for a wards, they will go to ICU just assess their IVC status. So what we do is only two things for us. We see basically IVCs, a collapsibility in the diameter typically below the episternum area, and another is a lung profile. So these are the two things what we commonly see. Uh, LVOT, VTI, if it is available, whoever are doing, we do it. Otherwise, these two things are enough for us to actually assess and start fluid accordingly. So euvolumic, hypervolumic, or underfilled or overfilled. These are the three things what we see into it. As we already discussed before, if it is underfilled, definitely focus is going to help us. We straight away don't start early present for these patients because even plasmolite, balanced salt solutions, and albumin will actually take care of this perirenal AKI. We don't really have to give any vasopressors here. But yes, in case you feel that they are not responding and POCUS is telling you that they are well filled now at the end of, so we do twice a day assessment for these patients, morning and evening. So even twice a day assessment will tell us if that they are filled well. Now you can definitely try at the end of even 8 hours or 12 hours, you can start early present for these patients if they're not responding. You don't have to wait for 2 days or 3 days here. So yes, focus is definitely helpful. And especially in cirrhotic cardiomyopathy, these are the patients who are dangerous ones. And people who are is ACLF in ICU settings where terlipressin can be detrimental, especially the lung part, because once the lungs starts flooding, then we are at a difficult area because turning them around from there is very, very difficult. So we, as Dr. Rakesh already told, we try and maintain them on norepinephrine when they are in ICU. We do not use Turley in those cases, especially when the MAP is low. If and especially the diastole. If the diastole is falling below 60, especially below 50, then yes, vasopressin, especially then vasopressin will also be helpful to keep a map, a map well. That is the only thing. Initially, we used to be talking about 75. Now we talk about 80 to 85 map to maintain their kidneys well.
Okay, sir. Absolutely. POCUS is very much
This
important.
is the new thing. The target map has increased.
Yeah.
In
Yeah,
our
yeah.
in ICU settings, we are targeting a 60 map or
No,
65
no,
of
we should
No,
not.
that is
Totally.
no.
the
It
that
will
I think that
impair
message
your
should be
kidney.
yes.
Yeah, yeah.
Absolutely.
So,
That message should go down and to the everyone every
Mm.
stakeholder in the ICU. I think that's going to change the outcomes. Now that's a very
septic
valid
shock,
For yeah, for
75 to 80 is good, but for HRS, and we have to target a higher map,
absolutely.
specifically
absolutely.
when your patients are on RRT. We've shown that if you keep a low map on RRT, the patient will just crash and will never
Agreed.
come back.
Yeah, they will land up in ATN.
Yeah, yeah.
Yeah.
So renal
Yeah.
ischemia.
Mm.
So, sir, if you're suspecting cholemic nephropathy here, do you really push nephrologists to do a biopsy there? Or it is just
See,
an
doing
academic
a kidney
publication?
biopsy is a nightmare for the hepatology unit, especially when they're in the ICU and ACLF setting when the coagulopathy is very, very bad. We have done in few times transjugular kidney biopsies, but there is a lot of issues regarding the biopsy related problems also. So in simple urine analysis, as ma'am has already told, is enough for us to actually tell us, especially when the bilirubin is more than 20. And that is an area where bile cast and bile crystals. Simple urine analysis, we can tell our pathologists they should be trained to see that because they are routinely not. they are commenting on the granular cast and the routine cast in urine analysis. But if they are trend well in a fresh urine sample, definitely you will come to know. And especially when it is not responding to that early present, it is most likely, if bilirubin is more than 20, likely to be a coulommic nephropathy, unlikely to be anything else.
Definitely.
And they don't respond to it early. We have to, as ma'am has already told, we might have to go to extracorporeal therapies, maybe plasma exchange, or maybe a membrane therapies for them, because we need to cut the bilirubin down, get it down, and then definitely over the period, it immediately it won't start well. So these are non-oliguric patients. If you
Yeah,
see,
that's
they're
good to
not
know.
non-oliguric. So urine output is good, but the creatinine is not improving. The always creatinine is
Yeah.
around 2.53, 2 to 2.53. And that is an area where Plex, in our unit at least, Plex is definitely helpful for those patients. Ma'am,
That's
your
right.
say on this?
Yeah, Dr. Pavan, I totally agree. And that is why I was saying, in the APASL guidelines, if you see, I propose this that we are seeing this set of patients who have
Yeah.
high creatinine, non-oliguric,
Yeah.
and this is a different phenotype of stage
Yeah.
3 AKI. These are not the ATN patients. They are
No, they
making
are
poor
not.
in urine, very hypercatabolic, and they
Mhm.
have this is coulommic nephropathy. This is a
Yes.
phenotype that is coulommic nephropathy.
Yeah.
Now, as extracorporeal therapy has been commented, I have a few questions for Mahesh sir regarding this same topic. Mahesh sir, are you there?
Yeah, I'm here. Yeah, I'm here.
So, so now sir just told about PECs. So, so what clinical indications do you favor considering extracorporeal therapy? Where do you really consider PECs or you prefer DPMURs? And is there
So when
any
we,
robust evidence
yes.
for same? Where
So
we
Madam has in the last slide, I think in her presentation, she showed that double filtration plasma absorption system is superior to plasmapheresis. I would agree definitely on that statement because when you are comparing plasmapheresis with any other extracorporeal therapy, we should be very clear that how we are comparing and how we are removing the target molecule. For example, if you want to remove bilirubin from a patient blood circulation or plasma, so the removal of the bilirubin from plasmapheresis is straightforward. Blood goes into the plasma filter and plasma is filtered unselectively. Bilirubin comes out of the plasma filter. But the type of bilirubin removal in bilirubin absorption filter is different from the plasmapheresis. There is a particular ligand or ion exchanger where the bilirubin goes over that filter and it gets absorbed on that particular surface. So if you are very clear that you want to remove a particular toxin or a particular molecule, definitely absorption filter becomes a better option rather than a plain plasmapheresis. Because, for example, if we are doing a double ABO incompatible renal transplantation where we want to remove the incompatible antibodies, when compared with a plain plasmapheresis, particular antibody adsorption filter over performs than a normal plasmapheresis. So similarly, if you are very clear that you want to remove a particular hepatotoxin or a bilirubin or unwanted substance in a patient with significant hepatic injury by extracorporeal therapy, yes, plasmapheresis is not superior to any other adsorption therapy. I would go with the double filtration plasma absorption system. But the data is still lacking in a large randomized scale that what is the amount of bilirubin or what is the amount of toxin which is being removed from the patient circulation. Logically, if you want to answer that question, yes, I would go for DPAMS rather than plasmapheresis. But to offer it for each and every patient, the cost of the treatment is very high, and we need to anticipate the endpoint. For example, people are now very clear about offering ECMO for a patient who is having heart failure. If you are very clear that tomorrow, if the patient is going to get a heart transplantation surgery, you will reach that time with the ECMO. Similarly, what as an intensive care nephrologist, what I would think is by doing these extracorporeal therapies, the patient condition is to be reversed, and at the same time patient should be a prospective candidate for liver transplant surgery. Otherwise, the same molecules will be again, for example, after a couple of days or 2 or 3 days or 3 days, the same toxin or the same bilirubin will be normal in the patient circulation. So it will be of a financial challenge for the patient.
And which substitution you prefer, FFP or albumin, if you are
Obviously,
doing
FFP. There is no at this point. Obviously, FFP. I am not. If I am doing a plasmapheresis, not DPAMS, DPAMS definitely doesn't require any substitution fluid. If I am doing a plasmapheresis, I am very clear that I am very confident with FFP rather than albumin, because the amount of albumin, how much we have to give for this patient to prevent the vascular redistribution is very, very high. And at the same time, it is very costly. And definitely, it is not going to replace the coagulation factors for the patient, we are going to remove during plasmapheresis. I would go for FFP.
Thank you. Thank you very much, sir. My last question, after that we'll end the session here. It's a traditional and debatable question, but early RRT versus late RRT. In your unit,
Yes.
what you do?
Yes. If you ask, it's a very difficult question, but at the same time, it is an easy question also. 10 years back, I had a patient with decompensated liver disease. Patient was in mild metabolic acidosis, and I straight away I went ahead and have prescribed dialysis. My teacher asked me, why you are doing dialysis? You want to push the patient into permanent renal dysfunction or something like that. But the same clinical scenario now, if I am going across a patient with DCLD, and if the patient has some amount of acidosis, and if the patient is having hard indications for hemodialysis, I am doing hemodialysis and I'm comfortable in doing SLED also. It is not the timing of the renal replacement therapy which is going to make the major clinical outcome. It is about how you are prescribing your hemodialysis. See, the prescription of hemodialysis in this particular group of patients will definitely a big clinical difference rather than just putting them on a dialysis. If you randomly prescribe normal hemodialysis or SLED, that will definitely create some amount of hemodynamic instability, and the clearance on SLED will be definitely more than say CRRT. So yes, if the patient is affordable, CRRT definitely at any point of time you can go ahead and put CRRT orders. But if you are putting a SLED for this prescription, you can avoid the dialysis dependent stage, or you can at least prevent the ongoing ATN by doing a very slow dialysis, or by doing more changes in your dialysis prescription. I think rather than timing, your dialysis prescription makes a lot of difference in a patient with a decompensated liver disease or splanchnic vasodilatation. I would like to ask Girish sir also to comment on this.
Yes, I mean, that's for me, I am happy that Dr. Rakhi and Dr. Pawan both are agreeing to CRRT. And CRRT is something that should be done in patients with liver dysfunction. That is one. And in these categories, early is, I think, more beneficial because the biomarkers are also favoring the early initiation of CRRT. And I would definitely hope that in coming future, we may find ways how to do a regional citrate anticoagulation in patients with liver dysfunction on a CRRT. So that will be the something which we look up to the future. But definitely, yes, early CRRT is the way out for liver dysfunction and AKI. And I think
So,
that is a very significant takeaway from today's webinar.
so one point, when we 1 year back we wrote an article in the Indian Society of Critical Care Medicine textbook. It's a very short article. The heading is how to decrease the cost of the treatment for a patient, critically ill patient. The first thing is start CRRT at the first day itself when the patient is moderately sick. If you would start the CRRT at the early point of time, definitely you are maintaining everything in a proper control. If you delay if you start with by doing hemodialysis SLED, or if you wait till the hard indications becomes a major indications for renal replacement therapy. At that point of time, you won't be able to continuously do CRRT, and at the same time, the sweet spot at the initial point of time, where if you can do a CRRT and keep everything under your control and prevent the organ injury further, that will be a very fantastic thing if you can start the CRRT early. So to start to answer the question, early versus late, early CRRT will be a definitely a better option.
I have a additional question to that. Considering the cost issue, any experience the speaker or the panelists have on using SLED F, prolonged SLED F instead of using the CRRT machine on patient with cirrhosis?
Yes, definitely. If you need to be very clear about your SLED-F prescription, or hemodial filtration prescription. See, if you want to, the major difference between the CRRT and HDF at any particular point of time is there are two differences. One is how rapidly you are removing the ultrafiltration vis-a-vis the blood flows, and at the same time how rapidly you are decreasing the solute concentration in that particular patient. First, coming to the first thing, if you don't want to remove ultrafiltration, keeping in mind that by increasing ultrafiltration, you are hampering the hemodynamics of the patient. Yes, you can do hemodiafiltration with a very, very low ultrafiltration, or there is no problem. You can do hemodiafiltration by stopping the ultrafiltration, keep it in balance for at least first 6 hours. And if the patient hemodynamics, everything is fine, you can go ahead. And at the same time, yes, you can do hemodial filtration with 100 ml of blood flow also. This 100 ml of blood flow is same in HDF as well as in CRRT. So this blood flow can be similar, but please be very clear that you are removing the solutes rapidly in HDF when compared with the CRRT. So if the solute clearance that what you are doing is very rapid, and if it is causing some amount of brain edema, or if the patient sensorium is worsening, please be very clear to stop HDF. If that is not a big thing, then I think you can consider HDF if you have financial concerns. If that's what I can tell.
Brain edema is not a problem in cirrhotics. What I think, so there are two different things here. One is the ALF and another is ACLF with CLDs. Edema is routinely seen in patients. So if you are using primarily for the treatment of acute liver failure, hands down, there is nothing better than CRRT. SLED has not much role or not much study. But there are few instances where the patient, especially the rattled ones, when we have tried CRRTs, we have tried plasma exchange, and the ammonia is not coming down at all. In that area, sometimes we have used extended sleds slowly so that the ammonia can be cut down. But yes, that is the only area where we are worried about rapid flux of ammonia and the brain edema going up and down there. And rest of the things, if the hemodynamics are stable, I think SLED still has a role, especially in the cost constraint settings. Otherwise, CRRT, if you can do it, it's always welcome.
Yes, sir. Always
Absolutely,
CRRT.
absolutely. Agreed.
Definitely, there is no doubt. If there are no financial issues, obviously CRRT outsmarts any other modality. But if there are no finances, or if you are in a place where you don't have even a CRRT, yes, you can offer SLED or hemodiafiltration, but every time I am repeating the same word. It's not about the modality, it is how you are prescribing that HDF or SLED makes a lot of clinical outcome difference. So please be very careful when you are dialyzing a patient with a hepatorenal syndrome, or acute or in chronic situations. We should be very careful about the prescription. That definitely makes a lot of difference in the outcome of these patients.
It's been a really wonderful discussion here, but I think we have extended our time limit, and my team is asking me to stop here. So I'll close this session here. Thank you very much. Thank you very much, Rakhi ma'am. Thank you very much, Pawan sir, and thank you very much.
Thank you so much.
Mahesh.
Thank
Thank
you.
you.
Thank you
Thank
so
you.
much. Thank you.
It was really wonderful.
Thank you, everyone. Good
Thank you.
night.
Very much.
Bye
Good
bye.
night. Bye-bye.
Thank you. Good night
Bye.
and take care. Bye. Thank you.
Bye.
Good night. Good night. Thank you.